All right, well, welcome back to Ultrasound Grand Rounds this week. This is the first Grand Rounds of 2025. It is hard to believe that we are here, but we are. It was a good holiday season for a lot of us. I know there's some of that white stuff, some of that snow that came down for the holidays, and so that's always fun to mark the new year with a little bit of wintry weather. But anyway, we are back today. We're going to be continuing where we left off last time. In our last lecture, Dr. Werner talked to us about ultrasound of the liver, and today we're going to pick that up and talk a little bit more about ultrasound of the spleen. So without further delay, we are going to turn things over to Dr. Werner, and she's going to take it away and tell us more about ultrasound of the liver and spleen. Go ahead, Sandy.
All right. Thank you, Matt. So it's kind of funny that we're starting the new year with part 2, but that's just how it worked out. So we're going to start with liver and spleen with a pinch of pancreas, and we're going to start with part 2. So first is a quick recap of what we already talked about. And we started with the liver, and we talked about the normal appearance of the liver, the nice homogeneous appearance, the fact that it's got, different lobes. And we talked about the vascular system because there's the hepatic veins draining the blood away that go into the IVC, and then there's the portal veins and the arteries that provide the blood to the spleen, or the spleen. I'm already off on the spleen. The aorta, the liver, and then there's also the portal veins or portal system, which is draining the bile out of the liver. So it's kind of complicated, and you'll be happy to know that the spleen is not so complicated. And then we talked about some abnormal sonographic liver findings. We talked about the general homogeneity of the liver and how that should look. And we talked about what happens if the ducts are too big. We talked about vascular problems. We talked about different types of lesions, cystic and solid lesions and metastatic lesions and all of that fun stuff. So now we're going to go on and do that for the spleen. But you'll notice in very small writing there, we're also going to bring in just a little bit of the pancreas. That's not normally something that we look at in the ED, but it's there, and you should probably know how to recognize it and know that there are some abnormalities that you might be able to pick up. So we started last time with, a 30-year-old 30-ish-year-old female with right upper quadrant pain and epigastric pain. So we're kind of back there, and we're gonna go to the scanner, and not that scanner. We're going to the ultrasound scanner, or we're bringing it in most likely. So we're gonna take a look at the gallbladder, and the gallbladder. This is our long axis view, and it looks pretty normal. There's no pericholecystic fluid. The wall isn't distended. You can even see nicely down into the neck where there's that little fold there. So, okay. And the transverse view. And of course, we scan all the way through. These are only representative images, but the transverse view, no stones, no sludge. We've got a view of the CBD, which looks okay. So now we're kind of scratching our heads. And we're also noticing that there's this kind of, sort of homogeneous looking thing where we would normally expect to see the duodenum. So we're kind of curious, what the heck might that be? And the answer is, yes, it's the pancreas. So the pancreas lives really in the first part of the, right where the first part of the intestines, the duodenum meets the stomach and the rest of the intestines. And you'll notice that it's got a little tiny duct that's going out into the GI system. And what you can't see in this picture posteriorly is that duct coming out of the gallbladder and coming out of the liver is actually joining with a duct in the pancreas to form a common duct, and that all goes out into the intestines. And you can see the pancreas has its own nice little duct as well. And it kind of looks like, in this picture, it looks kind of like, corn kernels there. Doesn't really look like that on ultrasound. So on ultrasound, what should a normal pancreas look like? Well, here we go. So let's get some orientation. That's the left lobe of the liver. And then as we're looking a little farther down, this whole structure, and yes, I failed art in preschool, so I've never learned to draw, but this is kind of outlining the pancreas, and you can see it's a little hyperechoic when compared to the liver, and that's normal. And then some other parts you'll want to know, actually we have the head towards the liver. We have the body in the middle, and you'll notice that that's kind of directly over the aorta, and then the tail, which goes over towards the spleen. And then we have some other landmarks, the IVC, the aorta, and the spine behind that. So you'll notice that it's right near that SMA. So where the SMA comes off of the aorta, you should see the pancreas right kind of superior to that or on top of it. And some other things you'll notice, there's some vasculature just below the pancreas, the confluence of the portal vein and the splenic vein. And then the splenic vein coming over from the patient's left side. And then, of course, we have the splenic artery, and you can see it looks kind of tortuous, and that's how it's always described. So that's a normal pancreas. Oh, and then the pancreatic duct, of course, which is eeny, teeny, weeny, less than 3 millimeters. So it's often very hard to find that. And then the common bile duct is going to come in there as well, and the two will meet. But that's not seen in this particular image. So there's your normal pancreas. So this is the pancreas of the person that we were just looking at. And you'll notice that it's not more echogenic than the liver. It's kind of about the same, and it doesn't have like nice, boundaries. It's kind of boggy looking. And you can actually see that the pancreatic duct is visible. It's a little more than 3 millimeters, not a whole lot. And then you can see that there's actually some fluid around the pancreatic tail. And this is kind of the appearance of acute pancreatitis. So that kind of slightly large, boggy-looking pancreas. You may have a dilated duct. There may be some fluid around the pancreas, and that might lead you on to think, oh, this person doesn't have a gallbladder problem, but they probably have pancreatitis. And indeed, we had a lipase of 891, and we went and got some more history about that alcohol intake and determined that this was acute pancreatitis. And you may see someone who's had repeated bouts of acute pancreatitis and develops chronic pancreatitis. And in that case, you can actually see some calcifications within the pancreas. So we have our landmark of our aorta and IVC, and then in the forefield, you can see the pancreas, and you can see that it's actually got calcifications within it. And that's how it will look with chronic pancreatitis. And it may become more echogenic, or it may just be kind of maybe lower echogenicity than the liver and have some calcifications in it. And you're thinking about there was a lot of anechoic structure in there, and is all of that vasculature. And so you put some color flow on it, and you actually see that, no, it's the pancreatic duct. A lot of it is pancreatic duct that's actually dilated. So that would be abnormal. So within the spleen, you can have the generalized findings of pancreatitis, but you can also have all kinds of stuff, and it would take like another lecture to go through this. But one of the common things is the pseudocysts. So if you get pancreatitis, you can have a pseudocyst, and they are often in the tail. They can be anywhere. They can also be very, very large. In fact, we had a patient with one that was so large that it was thought maybe it was a positive FAST exam or it was ascites. And they stuck a needle in it, and it drained out this really brown, icky fluid, and it was determined that it was just a really large pancreatic pseudocyst. So if you see that, they can be very, very large. So this is, where'd my pseudocyst go? Oh, there it is. So this is an example of a pseudocyst, and they're very common at the tail, and typically they're anechoic. They don't have a lot of septations in them. They have good posterior through transmission. Good transmission. So they look like a common simple cyst, but they can be really, really large. And then this is an example of a pseudocyst that's very large. And so we're in the mid-epigastric region, and you can actually see the aorta and the SMA. You can see your vascular structures, the portosplenic confluence, and then you can see this big cyst above it. And that actually went all the way from the right to the left on this patient. So they can be really large. Okay. moving on to the spleen. I actually had an image in there of a pancreatic head mass too, because you can have tumors there. But my thing won't let me go backwards, so I'm going to skip that. So the spleen. Well, the spleen, as you know, it's lives right next to the kidney, except the spleen is intraperitoneal and the kidney is retroperitoneal, which gives us that nice fascial plane, and that's why you can have fluid accumulate there. And as you notice on this ultrasound, the spleen is quite a bit smaller than the liver. It's also a lot less busy than the liver. We don't have all of that vasculature. We don't have the portal veins. We don't have the portal ducts. We don't have the hepatic veins. So it's quite a bit more simple. Looks really homogeneous. So the spleen, first of all, the spleen, we just kind of think of it as something that we find on the FAST exam and take a look at and see if it's ruptured or not. But the spleen actually has some other functions. Although about 1% or one in a million people are born without a spleen, and then of course some people lose their spleens due to trauma and other things. And often the people who have congenital asplenia, they don't figure this out until autopsy. So, I'm not sure the spleen is really a necessary organ, but it does do some things. It filters the blood and gets rid of the bad stuff. It does have a role with the immune system, and it can sequester blood and then release it when it's necessary. Or in sickle cell, that can be a real problem because it can lead to a sickle cell sequestration of blood. Oh boy, I think I have to go back to elocution school or whatever it is. I can't relearn how to speak. Anyway, so the spleen on its own, it has vessels that come into it. So you actually have the splenic vein and then the splenic artery, so pretty good sized artery. And then of course it branches off. And the spleen has several recesses, one for the kidney, one for the colon, and then actually one for the stomach. So you'll see that those organs are right up against the spleen, and it's actually kind of built to fit those organs right next to it. So as you're looking at it, nice homogeneous, and that is actually the hilum of the spleen that you saw kind of going back and forth there, and you can put some flow on it, and you can see the splenic vasculature. So there's nice big juicy veins and artery right there, and then it goes up into the spleen. So typically your normal spleen is going to be homogeneous. Its echogenicity will be slightly less than the liver and less than the kidney, and about the same as the pancreas. There's not much difference. And then the shape, it's usually like a crescent. So how big is the spleen? Well, a normal spleen, it looks kind of normal. Looking at this one, even without measuring it, you're kind of like, oh, that's a really big spleen. It sort of looked like the liver, except that it doesn't have any of the vasculature in it. So how do I know what's normal, and where do I measure it? So here's our nice crescent-shaped spleen, and we're going to measure it two places. It kind of looks like a boomerang. So you're going to measure it from end to end in the boomerang, and then from the point of the boomerang right to the hilum. So those are the two places that you'll measure the spleen. And this one measures 7 by 3 centimeters. And is that normal, you wonder? And yes, so the size of the spleen, about less than 13 centimeters in length and less than 6 centimeters in width. So we're all good there. So here's an enlarged spleen, and you can see that there's some ascites around it. So you might be able to kind of guess at the cause. Anything that causes like portal hypertension is probably going to cause some splenomegaly as well. And just another example, even without measuring it, you can see that spleen is bigger and much easier to find than what you would expect from a normal spleen. Here's another example of splenomegaly, and you can see that kidney is actually sort of squashed, and the spleen goes on, and we're going down towards the left lower quadrant, and the spleen keeps going and going, and the spleen keeps going into the left lower quadrant. You can see it in the umbilical area. You can see it just above the bladder. And in fact, you can see it all the way over into the right lower quadrant. So this was actually from a lymphoma, a mantle cell lymphoma. And the patient came in with the complaint that he felt like he had a banana in his stomach. And it sort of looked like he had a banana in his stomach. And in fact, on CT and by ultrasound, he had a spleen that was sort of in the shape of a very large banana. So that's an example of extreme splenomegaly. And of course, that's at risk for rupture because everything is kind of stretched out. So you kind of worry about people with spleens that big. So what else causes this? Well, common CHF, portal hypertension, any of the lymphomas. You can have leukemia where the cells get sequestered in the spleen. Hepatitis, mononucleosis. We've all heard about, you don't let kids go back to sports with mono because they might have a big spleen. Well, you can actually ultrasound it in somebody who has mono and see if they have a giant spleen. And that would be a really good indicator for not letting them go back to football. Some other infections and hemolytic anemia because it's sequestering all those broken red blood cells. Some uncommon things, people who are born with the glycogen storage diseases, malaria can cause it, and very rarely myelofibrosis. And then one thing to keep in mind is that isoechoic hematomas might look like splenomegaly. So it's hard to tell. So in this video, you can see that there's actually some free fluid right around the tail of the spleen. So right at that lower tip. And you can see that the spleen looks really large. And it's kind of hard to tell, but there's actually an isoechoic splenic hematoma there, and you'll see that on CT, and you should be thinking about that when you see this really large spleen on a fast exam and don't have any other way to explain it, especially if there's a little bit of free fluid around it. So there you can see that little free fluid, and again the big spleen kind of pushing the kidney right out of the way. So you're looking at the spleen and you're thinking, what are those? Those are actually extra splenic tissue. Looks the same as the spleen, works like the spleen, but it's kind of outside the spleen. And this is another example. This was actually from a recent case that Bob Jones just sent me, and you can see that there's like extra splenic tissue around the hilum, and then right up at the superior portion of the spleen, right near the hilum, there's extra splenic tissue. We just saw that. So extra splenic tissue has multiple names. It can be a splenule, which might be known as an accessory spleen, a splenunculus, or a supernumerary spleen. And then, so those are usually small, 1 to 3 centimeters in diameter. They may be congenital, but sometimes if you have trauma to the spleen, like spleen cells grow outside the spleen. So kind of interesting. And it's more common if you have a large spleen. Now, there's another form of this called splenosis, and this is post-traumatic, and it's when you get implantation of the splenic tissue, particularly on the peritoneum. So it's like not next to the spleen necessarily. It's actually adherent to the peritoneum. And so you can think, oh, wow, there's some kind of metastatic disease there, and then go in and biopsy and find out that it's just splenosis. So that's something you would be thinking about, someone who has post-trauma and their spleen kind of reseeds itself on the peritoneum. And so just like in the liver, we can have a bunch of different lesions. So we can have cystic lesions, and you can have just splenic cysts, like this one, which is simple. It's round. It doesn't have septations. It's got nice posterior enhancement. So just a cyst. And then you can also have, like we saw in the liver, you can have lots and lots of spleens, or lots and lots of cysts. And that can be related to polycystic kidney disease. So you want to you look at your kidney and see if it looks like Swiss cheese, like your spleen does. So the splenic cysts pretty much post-traumatic, they can be post-infectious, post-infarct. So somebody who has a piece of their spleen that dies, they might wind up getting a cyst there. If they had an infection, as the infection cleared, it might wind up being a cyst, or it might be post-traumatic. You can also have polycystic kidney disease. Congenital cysts are rare. There can be parasitic cysts, and again, those can be when it's resolved, or even when it's an active parasite. And then you can have some vascular lesions that look like cysts. So this is an example of a fistula between the artery and the vein in this piece of the spleen, and that can sort of become a problem. So the spleen can also have solid lesions, just like the liver. And here's an example of a slightly hyperechoic solid lesion, and you can see that it's really vascular, and that should make you worry a little bit about some type of malignancy. If it's not very vascular, it's more likely to be benign, but we can't say that for sure, so they all need follow-up. So the solid splenic lesions, hemangiomas are the most common, and then there's a whole bunch of other things. You can get Mets in your spleen. You can have infarcts. You can have abscesses. You can have granulomatous disease, and you can also have hematomas. So this is an example, and you can see at the superior portion of the spleen that there's some very hyperechoic solid lesion. And unfortunately, this person was lost to follow-up, so I can't tell you exactly what it was. And then this is an example. So doing a fast exam, just doing a regular fast exam, this person has all of these granulomas, and we got a CT, and you could see there's a couple in the liver, and then there's a whole bunch of these little calcified things in the spleen. And so we're like, where did those come from? And so some of the things that you can think about with calcifications, oh, where'd it go? Okay, can't go backwards. So you can also have sarcoidosis, which is going to leave you solid lesions that actually look somewhat target-like, which may also make you think about metastatic disease. And this is an example of metastatic disease, sort of looks cystic, and it's actually from an ovarian cancer that's metastatic to the spleen. And then this is an interesting spleen. It's sort of like, okay, half of it looks hypoechoic to the other half, and half of it has blood flow, and the other half doesn't. So you're wondering, what is that spleen? And I will tell you that this person's spleen got ultrasounded a whole lot because they kept coming back with left upper quadrant pain. And what had happened is they had had a traumatic rupture of the spleen. And so they cauterized it, put in a coil, but left some of the splenic tissue viable. So what you could see was the dead splenic tissue versus the live splenic tissue. And after a while, they came back 8-9 times. We stopped ultrasounding them because they'd always been negative, and then they stopped coming back. So that's just a nice example, and you can see really clean delineation between the infarcted tissue up at the top and then, or to the left side on the screen, and then the normal functioning splenic tissue inferiorly or to the right of the screen. So that would be a nice example of an infarct. And then this is something that we had talked about before. So we're in our splenic view, and you can see nice spleen. You can see kidney. And then you can see something on top of it. Now, recall from your previous lecture, this had a really unusual name. It's normal. And it's the liver over the spleen, and it's called, yes, the beaver tail liver, which I think is one of my favorite little analyses there. So you can see the beaver's tail flopping right over the top of the spleen, and that's just a normal variant. So there you go. And then one other thing that you want to watch for the spleen is sometimes you're not posterior enough and you're trying to find that view of the kidney, and you see something that looks like it might be free fluid. And you're like, ooh, is that a positive fast? But there's stuff in there, and maybe there's air in there, and I'm not sure what's going on. And so this is someone who's probably been at the baseball game. You know, they fell off the bleacher, probably not from too high. They don't have any pain anywhere, but you're doing that fast because they're pretty intoxicated. And that's actually the stomach. So just something to keep in mind, if someone has a really full stomach and you're not seeing that kidney, it probably means that you are just not posterior enough. So about that splenic hilum. So this was a case of someone who came in with abdominal pain, primarily on the left side. They did not look very good, and the team who was caring for them thought, oh God, it's an aorta. And they started to look at the aorta, and there was all this stuff, and they weren't sure what they were seeing. So I got called into the room and I was like, well, the aorta, okay, that's the aorta there with it's like 1.28 centimeters, and you could sort of follow it down, and there was nothing wrong with the aorta, but there's this thing right next to it. It's like, what the heck is that? So it's like, big mass, ugly thing that just kind of conforms to the space. And in the left upper quadrant, you can actually see there's some free fluid up there as well. I don't think that's a video. So right up here, you have some nice free fluid. And there's no color flow in that currently because it's all clot. So don't forget that aneurysms are not just limited to the aorta. So this was actually an aneurysm of the splenic artery. So a huge amount of bleeding. Fortunately, we figured out that this was all blood, and the patient went to the OR, and actually they became asplenic because they took the spleen right out. All right, so the spleen summary: homogeneous, less than 13 centimeters, less than 6 centimeters in width. The 13 centimeters is in length. And then splenomegaly, the common things, anything that's going to cause portal hypertension, so any of your liver disease, your CHF, lymphoma is a big one, and then infectious stuff like hepatitis, mono, and then also hemolytic anemia. So if you have somebody who's breaking down their blood cells, they are going to wind up in the spleen to be destroyed. And then the uncommon things are glycogen storage disease, malaria, and really rare is the myelofibrosis. So we talked about the extrasplenic tissue, the difference between splenules and splenosis. And then we talked about different types of cystic lesions, which are usually the remnants of infection or infarct. You want to check for polycystic disease if you have a whole bunch of them. And then think about a parasitic disease and also mimics, and sometimes congenital. And somehow the slide that I was going to talk about on solid lesions didn't show up. So the solid lesions can be hemangiomas, hematomas, lymphomas, metastatic disease, infarcts, abscesses. And what we saw with that granulomatous spleen was actually the person had lived in the Ohio Valley for quite a long time. And it turns out that histoplasmosis is very common there. So it was probably due to histoplasmosis. The other common thing that causes granulomas, though, is tuberculosis. So in the right setting, you want to think about TB if you have somebody with those nice calcified granulomas in their spleen. And then, of course, hematomas. So don't misinterpret it, hepatomegaly or the stomach in the left upper quadrant window. So if you have a big liver that's crossing over like the beaver tail, don't add that to the spleen. And then also think about clotted blood or being an isoechoic splenic, what's the word I'm looking for, splenic hematoma in there. Take-home point, scan through the liver and the spleen. And then, of course, if you have weird stuff that you can't explain, you want to get additional imaging or follow-up, and that's required for most of these weird lesions. I mean, if it's something simple like splenules and you're comfortable with that, great. If you're not, get additional imaging, get somebody else to take a look at it so that you don't miss something bad. Okay, so I think we've covered just about everything for the liver and the spleen. Any questions, comments?
Well, thank you, Sandy. That was amazing. I always enjoy hearing this talk over the years as you've kind of grown and developed and expanded that, just because there's always such good stuff in there that I learn every single time. they're there. We scan them all the time. The liver and the spleen, as we go past it with all these different studies. And so just to sit down and think about it is like, what can we see in these different organ systems as we just kind of blow past it is always very helpful. So thanks again for presenting today. I think that was
Sure.
very helpful. Any questions from the audience, anything that you guys want to ask or talk about, with regards to the spleen or scanning it, Diane, if you have anything that you wanted to share? All right. Well, thank you guys for joining us today for Ultrasound Grand Rounds. Sandy, you gave a great set of lectures here on the liver and the spleen. I'm sure everyone else is going to enjoy these thoroughly. And if you are enjoying these and want to learn more, go back to the YouTube channel, or if you're on the YouTube channel, scroll back to other videos, hit that subscribe button, that notification bell, so you know when these things come out right away. Look at all the other content. We put a lot of stuff up there to help you with your point of care ultrasound scanning skills and abilities. Next time, we're going to talk a little bit more about the gallbladder to wrap that up, and then we'll move on to other topics, probably a little bit of kidney, some other things kind of throughout the spring. So hope to see you guys in the next installment of Ultrasound Grand Rounds in a couple weeks. Have a good week. Happy scanning. See you guys. Bye.